Welcome and thank you for joining us for today's Mastermind session, Quality Improvement in Chronic Kidney Disease and General Practice. My name is Sydney Cruikshank and I'm from the PHN Education team. And I'm joined today by my colleague, Deborah Wolgansky, who is a Primary Care Improvement Officer with the PHN, as well as a subject matter expert in chronic kidney disease. Before we begin, I'd like to acknowledge the traditional custodians of the land that I live and work on. For me on the Central Coast, that is Darkinjin land, and I'd also like to pay respect to elders past, present, and emerging. A few things to let you know about the session. It will be recorded and available for you to view in our education library in a few days' time, as well as a copy of today's presentation slides. As attendees, your camera and microphone are automatically disabled. However, if you have any questions during the presentation, you can pop them in the question box, which is just located within your control panel. An evaluation will also come to you directly after today's session. Any feedback you can give us would be extremely appreciated, as it allows us to provide future education. Now it is my great pleasure to introduce you to Deborah Wolgansky.
Oh, hello, everybody. Thanks for coming in today. We use the term subject matter expert loosely because I'm not a renal nurse. I'll just put that out there. I'm a registered nurse and a midwife, but not a renal nurse. But quality improvement. So let's get cracking. So today I'm just going to take you across a few statistics, some quality improvement resources. We're going to look at the risk factors, the kidney health check, some diagnosis, staging and clinical action plans, and monitoring and management. Those have all been put forward by Kidney Health Australia and their primary care guide. So this here is the Australian Institute of Health and Welfare. This is the 31 PHN boundaries across the nation. And I just wanted to let you know this is crude rates. They're not age standardized, but the first column is the prevalence. So our PHN boundary, which includes the Central Coast and 100 New England regions, we're fourth worst out of the 31 PHNs. For the hospitalization rate in the middle, we're third worst. And for the death rate, we are second worst. So a little bit of work to do there with that burden of disease. So more locally in New South Wales, by local government area, the areas in dark blue are the problem. So all New South Wales LGAs are sitting about 56 deaths per 100,000. However, Cessnock, Gunnedah, Moree, and Tamworth, you can see those rates there are up in the 70s in the dark blue areas. So a bit of work to do in those LGAs as well. So the things that we do at the PHN for quality improvement are to provide a dashboard that shows you your practice disease prevalence. So chronic kidney disease is listed there. For example, this practice could have 43 chronic kidney disease at that particular practice. However, one thing I really wanted to point out is that our dashboards also show you the indicated chronic kidney disease, but not diagnosed, at least by a coded diagnosis. So your CAT4 software that the PHN provides a license for, it will crunch your pathology. And so, for example, this particular practice, 369 persons have some sort of pathology there that's indicating chronic kidney disease, and yet they haven't been coded with a diagnosis. It very well could have been a freehand typed diagnosis, but that's not readable by software. So a little bit of work to do there. Some risks for chronic kidney disease are in your dashboard. So diabetes prevalence is listed and hypertension prevalence is listed. Also, you'll find your Indigenous cohort there. And just to note that we also provide you the ethnicity not recorded. So for example, this practice has 157 patients with ethnicity not recorded. So that's a risk factor for CKD, and so obviously we'd like that to be coded with whatever the patient says their origin is. So lifestyle risks, so weight is a risk factor, and so you can see the green healthy weight range, and then going upwards. Also too, that has a not recorded, so this particular practice has 1,800 records without a coded BMI, so the height and the weight in the right observation box in the software. And likewise the smoking, so there was 1,100 smoking status not recorded at that practice. This here is the Aboriginal and Torres Strait Islander Health Assessment, so the 715 item number. So this practice has 163 Aboriginal and Torres Strait Islander patients, but 132 health assessments are outstanding. So these dashboards are very useful. Your primary care improvement officer can provide them to you quarterly. We also have a program called LUMOS, and LUMOS reports on chronic kidney disease for admissions to hospital as the main diagnosis, and also additional diagnosis at admission. So that's quite good, because you can have a look at how you compare with admissions compared to New South Wales PHNs and practices within this PHN. So what we've built is 4 quarters of quality improvement activities, because they partner with the QI PIP incentive program. So this is a nice easy way for a year. You can do 4 of these in order. Basically, we look at the beginning of the patient journey, so patients at risk. Then we look at patients without a coded diagnosis. Then we look at chronic disease GP management plans and team care arrangements and nurse item numbers. And then finally, looking at the clinical action plans. So these are really nice and easy. You can use our template to define your baseline, define your activities that you'll do for the quarter, and then at the end of the quarter, study your results and act to tweak your activities. This is a 12-month quality improvement record. It's a nice, easy way of doing the QI PIP incentive program with CKD for a year. Okay, so yeah, this is the document I was speaking of earlier, the Kidney Health Australia Chronic Kidney Disease Management and Primary Care. There's also an app called CKD Go that you can pop on your phone. It has some nice tools there, and just download that from Apple or Android. So that's quite handy. So risk factors for CKD, so diabetes, hypertension, established CVD, family history of kidney failure, obesity, smoking, 60-year-olds, but not of its own, some Aboriginal Torres Strait Islander, and history of AKI. So we partner the handbook with the CAT4 report, which also has conveniently a CKD at risk report. And then we partner that with that first quarter's activity so that you're finding these patients. So this here is the CAT4 report for CKD risk. So each of these red or black boxes you can click on, or multiples of boxes, and the risk factors are tabulated there in those columns. So you can get your patient names. PHN, we don't see any patient names, but we can help you re-identify inside your practice. So it will come up with a worksheet as well, and that's how, for example, a nurse would get the patient names and recall them into the practice for a proper kidney health check. So the kidney health check, yep. So CKD is usually asymptomatic. 90% of function can be lost before symptoms become apparent, and persons may not notice those symptoms until they're actually at stage 5, which is pretty much a dialysis referral. So a kidney health check is very simple. 3 things: blood test, urine test, and blood pressure. So the indications for this are those risk factors that we talked about. The frequency of that is every 1 to 2 years, except for with diabetes or hypertension, when it should be done annually. For Aboriginal and Torres Strait Islander persons, it's divided into 2 cohorts. So one is persons age 18 to 29 without any risk factors. And so during that 715 health assessment, we should be screening for the risk factors. Alternatively, if a person 18 to 29 does have those risk factors, or for everyone over age 30, they should just be going to a kidney health check, and that can be done in that health assessment. So once you're starting on the kidney health check algorithm, so the EGFR and the urine ACR, and don't forget about blood pressure. But so abnormal EGFRs and abnormal urine ACRs, they need repeating. So they'll need repeating when they're under 60 or elevated for males and females. So repeating these twice within 3 months, because the diagnosis is when it's existing for 3 months or longer. So what I recommend is give the patient 3 path forms, 3 urine pots in a baggie, get them to do the first one, read the results, call them and tell them to do the second one or not. You can say you're fine, throw those other 2 in the bin. And then the third one, if you can date that one at 3 months and 1 day, then you get your diagnosis pretty easily. However, diagnosing CKD is a little bit tricky, I guess. So you can either have the EGFR decreasing, or you can have kidney damage shown by albuminuria or other structural issues. We have a report in CAT4 that shows you the patient names when this path drops in, and yet they're not coded for the diagnosis, mainly because CAT4 only reads the most recent pathology. And like we said, you need 3 readings. So it does need clinical input. But we've built the next quarter activity to help you through that. So this is really the grid that talks about the diagnosis. So it can be, as we said, due to decreased kidney function, which is where you get your stage 1 to 5, or it can be due to kidney damage and also from albuminuria. And structural things as well in the green box there. So moving on. Right, so to fully specify a CKD diagnosis, it's important to know that it's not a diagnosis primarily by itself. There should be attempts made to find out what the cause or the underlying reasons for this are. So you do need the EGFR, and that gives you, as we said, the kidney function and the stage. You do need the ACR result to determine what level of albuminuria. You do need the underlying pathology as a cause, anything structural, and that will give you your diagnosis. So a complete diagnosis would be something like stage 2 CKD with microalbuminuria due to diabetic kidney disease. So that's a nice full diagnosis. So with the coding of it, there are a couple of requirements for accreditation through the 5th edition standards. That requires that you do use a recognized medical vocabulary for coding in your software. Also, the eHealth PIP requirement, you do need to use that national vocabulary so that it can populate the shared health summaries. And the eHealth incentive requires you to have a practice policy to that effect. But fortunately, that national vocabulary is already embedded in clinical software. For example, medical director and best practice. They use different languages, DOCL or SNOMED. There'll be other languages out there for Genie, for example. But these coded diagnoses are what they say: chronic kidney disease, stages 1 to 5, which we talked about in diagnosing, so that's good. So in best practice, the way to do that is to search chronic kidney disease and pick from the drop-down list and code your diagnosis that way. If you hand typed it in the past, you can click on that past history item and edit it, and again, pick from list so that you're recoding what you've already diagnosed. Medical director is very similar: pick from list, type it in and grab one of the stages, and again, you can edit that as well. That's a nice way of cleaning those up. However, there's a really cool tool in Best Practice NMD. This one's under BP Utilities. It's its own app on your start button there, and it's cleanup history, and it's really cool because you can just, this one's got diabetes loaded, apologies for that, but you can just type in, look at the uncoded items in the list and select one in blue, and then on the right-hand side, also type in what you're wanting to find, select the diagnosis you want, and simply push replace, and it will replace multiple records and recode them for you. Here's the medical director version. It's in the maintenance app, and it's under medical director clinical, diagnosis coder, and very similarly, you find what has been hand typed, find what you want to code to, and correct that. So that's nice. The other thing I was going to say is just check that your duplicate patients are always very clean, because you can have multiple records for the one patient, and sometimes pathology is in one and the diagnosis is in the other. So CAT4 reports can help you find duplicate patients by name or by number, and then just have a look at their birth date and address and gender, etc. And then you would merge those in your clinical software. So this is really the big tool in CAT4. This is how to data cleanse on the list of patient names in your practice. There's a pretty nice set of tools about how to navigate. So you can double click on a patient name. It will take you deep into your clinical software where you can recode it right then. You can click on these columns to sort them. I like to sort them with the red or the worst pathology at the top. And then you can review their record. You can elect to confirm condition does not exist, and then you remove them from the list, but knowing that you can always come back and review your removed list, and also knowing that when pathology comes in, they'll reappear on the list. So that's a nice way of cleaning up records as well. So just to have a look at the chronic disease management. So we do the third quarter on building GPMPs and TCAs and using nurse item numbers. So there's nice reports in CAT4 to look for eligibility, but where a GPMP has actually not been built, and TCAs, and you can use all these other allied health and specialists, because there's an awful lot of common issues in CKD that need that multidisciplinary care. So for the fourth quarter, what we would be suggesting is that we're looking at the clinical action plans. So these are either yellow, orange, or red. They vary from every month to every 3 to 6 months and up to 12 months, depending upon the acuity. But there's a lovely report in CAT4 that tells us where we're up to with our management. A bit similar to, say, the diabetes cycle of care. There are a number of items that you need to do for each person with CKD. So here's a nice example of a report in CAT, the staging report. So if you were to click on all of the patients that needed a clinical action plan every 1 to 3 months, it would be these red boxes, and that way you would be able to re-identify their names and check that they're up to date with the management items. So this is the yellow one. These are cumulative. So the yellow one, it has a plus, and then you add the orange one when they're a bit more acute every 3 to 6 months, and then obviously you're adding the yellow, the orange, and the red tasks for the 1 to 3 months. With the management items, I just wanted to bring to your attention that the whole of practice approach is across all 3 of those, and we kind of address that with the team care arrangements for nurse item numbers. So this is the management report, which actually lists out the 8 items that need to occur as per that management plan. So whether it's blood pressure or BMI or HbA1c or smoking, there's a couple of medicines there. So the ACE and ARB category, whether it's prescribed or not, and the statin category, whether that's prescribed or not. So just to let you know, there is some definitions around that you can get time frames for when things appear in the management report or in the risk report. So just a bit more definition around when they're appearing. So just wanted to talk about dapagliflozin for a minute. That became listed on the PBS last September. And so it's the first kidney drug in 20 years at less cost on the PBS, and also with the indication of CKD. So 45,000 Australians could benefit, and reducing 17,000 CKD deaths, which is game-changing, really. So there are some indications for prescribing that, which would need clinical judgment. I'm sorry to say MPS funding wasn't renewed and NPS no longer exists. However, it did have a nice prescribing guideline there to look for the EGFR and the ACR and the medications for eligibility. So in CAT4, you can look at the EGFR to try and find the names of patients in that group for prescribing, sort of EGFR 25 to 75. And you can also find the ACR there as well. So that's prescribing for, say, 22 to 565. So you can click on those bits of the pie graph and get those names. And there's a really cool way of saying no to the filters in your CAT4. So for example, in the middle picture here, you'll see that the SGLT2 has an option for saying no, not prescribed. And so like dapagliflozin was a diabetes medication, and so it's actually in your CAT4 under medications anti-diabetic. But if you say no to that and you say yes to kidney disease, then you'll get a list of patients who aren't prescribed it and probably should be, depending upon their pathology. So that's a nice report. It is a cross-tabulated report, and you can tell that by the bottom picture where it's got a black dot next to the pathology. And so that's cross-tabulating with another report. And then at the top of your CAT4, you can see the big green button there. So that's how to get a cross-tabulated report. So just to let you know that the primary care improvement team at the PHN here, we do have information on our website. For example, this tile is called chronic kidney disease, and you can find most of what we've talked about today on there. You can also find phone numbers so you can contact your primary care improvement officer, and if you need me to help, I'm more than happy to help out as well. Health Pathways is up to date on the Central Coast and Hunter, New England with their chronic kidney disease management and referral guidelines. So they're handy for you, and also patient info, so information that would be health education, health promotion, that kind of thing. So there are chronic kidney disease and prescribing and nephrology referrals on both pages. So that's quite good. And yeah, that's another example of what it would look like. So just to go over what we went over, so we looked at some stats that were pretty compelling for action. We looked at some quality improvement tools to plan your activities. We did look at the risk factors as per Kidney Health Australia, the kidney health check, simple 3 things. We looked at diagnosis, which that grid can help you to determine. And then staging is very important because that's what informs our clinical action plans. And then the monitoring and management activities that happen individualized for the appropriate time periods for the patient. So that is it from me, and we're at 1:23, so we've got about 7 minutes for questions.
Perfect. We had one question come through now.
Oh yeah.
I honestly cannot pronounce the first word, so I do apologize. It says dapagliflozin.
Yeah.
Yeah, you know what that is. not on Health Pathway, Hunter, New England, as local specialists wanted to wait for it to be included in KHA guidelines. Do you know if this is going to happen?
It's a good question for the peak body at KHA. It's certainly in the PBS, and it's certainly in NPS, and it certainly got a lot of media attention. So it's a good question. I can't tell you if KHA have embedded it, but how about I ask and get back to you?
That'd be great. I'll make sure I've got the email address and stuff, and we can.
Thank you. That would be great. That'd be great.
Now, that was the only question for today. So besides that, we'll finish off the webinar. The evaluation will come straight through to you. But if you need anything else, check out our education library.
Perfect. Oh yes, it'll be recorded, won't it?
Yes, so the recording will be up in a couple days' time, as well as all of this PowerPoint presentation too.
Okay, perfect. That's great. Thanks so much, Sydney. I hope it was enjoyable to everybody, and feel free to reach out if if I went a bit fast.
Perfect. Thanks so much, Deb. Appreciate it.
Okay, thanks very much.
Bye.
Bye.